Well, good morning, everybody. We're going to have a special morning. My name is Maggie Atwood, and I am a member of the Chats with Champions Committee. And it's my pleasure to introduce our speaker today. Before I do that, I'd like to thank Mel Gormley, who is handling our video today. And I'd like to remind everyone that our next Chats is this Thursday, October 8th, at 10 o'clock here in Porter Hall, when we will have Channel 13's meteorologist Charlie Lopresti speaking. All Chats presentations are open and free to the public. There is a donation basket on the table, and all donations are very much appreciated. At this time, I would like to request that all electronic devices be turned off. Our guest speaker today is Dr. Stuart Gilbert, former radiation oncologist at Maine Medical Center. Educated at Colgate and Tufts, he did his residency at Boston City Hospital. He moved to Maine with his family in 1976, at which time his career at Maine Medical Center began. His experiences, his honors, his academic appointments, and his published papers are numerous. He has written a book entitled, "When You Hold a Patient's Hand, Don't Wear a Glove." It is a moving testimony to his belief that treating the human being is as important, if not more important, than simply treating the cancer. His talk today will be on some of the people and patients with whom he worked, who, in his words, he says, taught me a lot about life, how to live it, and how to leave it. His book will be on sale after his presentation. And by the way, the book sells on Amazon for $14 plus postage and handling, and at bookstores for $15, but he has very graciously said that he will sell them to attendees today for $10. On a personal note, I just want to add that when I was dealing with my own cancer adventure, Dr. Gilbert was my radiation oncologist. During that period, I saw a lot of different doctors, and in my professional life, I have worked collaboratively with many more doctors over the years. Not one of them came close to offering the intelligence, attention, patience, and compassion that Dr. Gilbert did, and I am still grateful for that. Please welcome Dr. Gilbert.
Thank you, Maggie. I want to thank the committee for the invitation. When I looked at the list of previous speakers at this meeting, I was very impressed and very honored to be included with them. And I would especially like to thank Maggie Atwood for all the emails and getting me ready for this talk. I'd like to dedicate my talk to a good friend and a valued colleague who passed away this past winter, and it's Dr. Frank Galvantaggio. He's a friend of the library. I know that was his job after retiring from surgery. And during my 33 years at Maine Medical Center and at the Bath facility, I dealt with all the surgeons from Kittery up to Rockport. And I can tell you, in my opinion, Frank Galvantaggio was the best surgeon in Maine, not only for his skills as a surgeon, but he treated all his patients as his own family. And when patients get referred to radiotherapy, the referring doctor kind of drops out. Frank would call me and say, "How's my patient doing? And is there anything I can do on my end to make it easier?" And so, as you can see from my book, caring for the patient goes high on my list. And he was one of the most caring, gifted people. Harvard trained, he could have gone any place. And Dan Scott was very fortunate that he chose to have his career here. I came to Portland in early January 1976, and since then I've had a very fulfilling career, and I particularly enjoyed coming to tumor conferences at our regional hospitals. Once a month I was at Tumor Board of Miles for over 20 years, and really enjoyed the camaraderie with the excellent medical staff here. Radiation oncology offered me a great opportunity to treat patients at a very critical time of their life, when they're vulnerable and desperately in need of a helping hand. And I had no intention of writing about my career, but I had all these stories and experiences with patients and letters from them, and shared them with friends and family, and they said, you better write these down before you forget them. So I sat down on my computer and I just did Word documents on each experience, and I had about 45, 50 of them. And then I looked through them and I said, gee, there's a theme. And the theme which we quoted was, when you hold, it's just as important to treat the individual and the family attached to the cancer as it is the cancer themselves. And so that once I saw this theme, I said, gee, maybe I can weave these 50 Word documents into some sort of book. And I did, and the title of the book is When You Hold a Patient's Hand, Don't Wear a Glove. And I've had previous discussions, people say, well, what do you mean by that title? And I go to a quote from Dr. Rachel Revin. I don't know if anybody's read Kitchen Table Wisdom, but it's a terrific book. And she was a pediatrician, then became a psychiatrist, and really concentrated on counseling patients with death and dying or severe illness. And one of her stories in the book tells about a man who was dying of cancer, and he says, in thinking back, I have a clear memory of many of these, of many climbs with my son. We hikes and climb mountains, and then he said, in thinking back to it, I remember all the details of the climb, but I don't have no memory of anything my son said to me or I said to him. And she writes that, quote, many people live their lives in this way, sharing homes, jobs, and even families with others, but not connecting. Too often we even practice medicine this way, side by side, patient and physician focus on the disease, the symptoms, the treatments, never seeing and knowing each other. The problem gets in the way and we're each alone. And to make an example, or to give an example of what I mean by touching a patient's hand, I decided to use a patient in his 70s who was dying of lung cancer. I was treating him for a painful bone metastasis, and he was near the end of the treatment. And in the examining room, I said, how are you doing? And he said, well, the pain's getting better, the treatments are working, and I have pain medicine at home, and I'm eating okay. He said, one thing that really bugs me is that every time I try to talk to my son about stopping smoking, he gets very upset, stands up and says, I can't do it, especially now, and he walks out of the room. And I said, do you want me to talk to him? And he said, gee, would you? I'd really appreciate it. So I called the son in. I knew the son was devoted to his dad. He brought him in for many of his treatments. And he came into the examining room, and in front of his dad, I said, your father asked me to talk to you. And I said, if your father can take away the last 30 years of his smoking, he'd do it in a second, but he can't. I said, however, if his illness is the reason for you to stop smoking, then some good would come of his illness, and he won't die in vain. And then, since it was November, I poured it on. I said, this is probably your dad's last Christmas, and the one Christmas present he wants from you is to stop smoking. And I said it would be the least expensive gift you've ever given, but none would be more precious. And the patient finished his treatment. I gave him an appointment to come back in a month. And before he came in, he got a chest x-ray, and I saw that his tumors were growing, so his tumor was progressing. And the nurse had weighed him, and he had lost another 5 to 7 pounds, so I knew he was failing, and I really didn't have anything good to tell him. And I opened up the examining room and walk in there and greet it with a patient with a big smile on his face. He gets up and shakes my hand and says, "It's been 17 days since my son had his last cigarette." And, you know, it's not science, and it's not a billable event, but it's what he needed. And that's what I mean by the title of when you hold a patient's hand, don't wear a glove. When I look back over my 33-year career at Maine Medical Center, I realized how much I changed and evolved over the years. You know, in the first decade of my practice, nobody was going to die on my shift. My biggest fear was that I wouldn't do enough, I wouldn't do the right test or the right treatment or enough treatments that could have made a difference. And so I like most young doctors, you know, overtreat and don't want to give up. By the third decade of practice, you realize that aggressive oncologic care very often shortens people's lives and certainly decreases the quality of the remaining life. And so you get to be more balanced. I do have a chapter in there about don't stop too quickly. Because there's some patients who I wouldn't have given any chance at all of having a good response, but you start treatment and the tumor starts disappearing, and sure enough, some of these patients will walk away and be cured. So it's very humbling when you realize that many patients will ask me how long do I have to live, and I would tell them, I used to know the answer to this, but now I know I don't. And so you really have to go one step at a time. Most of the lessons I learned were from some amazing and inspirational patients and families, and they taught me a lot. And let me give you a couple of examples. First one is a 47-year-old woman who presented with a small right breast cancer. She had seen the general surgeon. This is in the 1980s. And the surgeon said, you should have a mastectomy. And the patient was a very bright lady who was an assistant superintendent of schools. And she had done her homework. She realized that lumpectomy and radiation was being reported by individual institutions, and the major international studies have not been completed. They were in the process. But now we know that lumpectomy and radiation is just as good as doing a mastectomy. But she did not want to be, her words, mutilated. And so she and the surgeon came to an impasse. And he finally called me, and he and the patient agreed that rather than make a decision that day, she would come and see me, and then we would discuss the options, and then the surgeon would do whatever we had decided. So she came to see me, and she was very well prepared. She knew all the data of the small individual reports. And I have to remind people, most of you were around in the 80s, but many of my audiences were not. And in the 1980s is the time before Google. So if you wanted to do research and look up articles, you came to the library, look up the indexes, and then they would give you citations, and then you have to search for the book or the, very often one library wouldn't have all these journals and articles. And so she did her homework. I don't know where she got it all, but very well prepared. And told me, she obviously took great pride in how she looked and did not want to be mutilated. And we talked and I listened and saw where she was coming from. And then I asked her about family history, and her mother and older sister both had bilateral breast cancer prior to menopause. And that was a huge red flag. Today we can order gene testing, the BRCA genes, and see if there is a family gene defect. And but couldn't do it then. But we had a long talk, and I told her that I believed in lumpectomy and radiation. I thought it was really a good treatment, and but she was, I thought, was a bad candidate for it because of the strong family history and her high risk of getting a breast cancer somewhere else in that breast or in the opposite breast. And we spoke for an hour and a half. Fortunately, she was the last patient of the day, so I was late for dinner, but that's okay. But at the end of it, she agreed to have bilateral mastectomy and reconstruction. And I called the surgeon, and the surgeon was very surprised, but he went ahead and did it. She came in the hospital, had her surgery, and 2 days later, the pathology came back that she had the expected right breast cancer, but also had a small angry cancer on the left side of her. And I went to see her a day later while she was still in the hospital, and she thanked me for the consultation, and she said, "Thank you for saving me from myself." And the tumors on both sides were very small, and the margins were more than adequate, and the nodes were negative, so she never received radiation treatment, and I never saw her again. And that would be the end of the story. A year later, I received a small package at home, and in the package was a small silver bowl and the following letter, which I'll read the edited portion. Dear Dr. Gilbert, nearly a year has passed since I visited your office for a consultation prior to surgery for breast cancer. You probably do not remember me or my particular case because of the number of patients which passed through your doors. There's some patients it's hard to forget. However, your meeting with me and your recommendation to me are landmark experiences in my life. Because of your meeting with me and because of your recommended course of action, which was bilateral mastectomy, I believe that I was given the optimum chance of long-term recovery. What was remarkable to me is the length and depth of discussion we had. As a result of the information you shared with me and the answers to my questions, I felt that I understood what had happened to me and what my actual circumstances were and needed to be. I greatly appreciate your willingness to help the patient truly understand the disease in her particular situation. I called her last year, just gave her, if I could search patients down and show them the story I wrote about them, and she has done well, and she does have a breast cancer gene. Several of her cousins have breast cancer, but she taught me better than any lecture you can get in medical school is that you really have to. The patient has to be involved in the management of their case. And you have, by educating the patient, the doctors and the nurses, you empower patients to be able to make decisions. I often use the example of doctors may be the quarterbacks on the field, but the patient and the family should be the coaches who can send in plays and can change the quarterbacks anytime they want. And if you understand the whys and the wherefores of the treatment, you can tolerate them better, and you have a better result. And there are studies that prove this out. Another patient that taught me a lot was a patient that had cancer at the base of the tongue. And it's a bad tumor. And he he had some surgery, he had lots of radiation, lots of chemotherapy, and in spite of all of this aggressive treatment, the tumor recurred locally. Cancer of the base of the tongue is an awful way to go. You're choking, you aspirate, every swallow is very painful, and you have pain as the tumor invades the surrounding nerves. And he was failing and losing weight. And I saw him, and he came in, and he said, "Doc, I appreciate everything you've done, and I know you and your colleagues have done everything that's possible, and but don't worry about me. I know how to end this, and I plan to. Nobody would take any pleasure out of seeing me go to the bitter end with this cancer." And we talked for quite a while, and I didn't try to talk him out of it, and I really felt badly for him, and understood where he was coming from. And gave him an appointment to come back in a month, but I didn't expect to see him again. And a month went by, and he came into the office for his appointment. He had gained 10 pounds, and he looked terrific. And I said, "Wow, what'd you come up with? Tell me your secret." And he said, "Well, a strange thing happened on the way to the cemetery. My wife had an abnormal mammogram, now she's getting treated for breast cancer. And so he had a mission, and he had to take care of his wife. And so he took his insurer and his pain medicine, and was there to support his wife. He died 2 months later after she finished her treatments. But it showed, to me, I really identified with him, and I said, to myself, I do the same thing. I wouldn't want to go through the agony of the last stages of this disease, but if you have a reason to live, then patients can cope with it. And that became part of my routine. When patients have metastatic disease, they know it's incurable, and they have one thing after another, a pain here, discomfort there. And I would tell them, I said, we're all going to be dead for a long time. And is there anything you want to do while you're still on this planet? And it's amazing what answers you get. Patients say, "Oh, my brother lives in California, haven't seen him in years," or a child, or a good friend. And I'd say, "Okay, well, you have the power of your diagnosis, and you have to use it. And call up your friend, and the answer is, gee, I wish I could get away, but I can't." You say, "This is the situation, and I don't know how long I'll be here, and I expect you to come and visit me." And then you can add that, I'm a very selfish person, and I want to see you, and if you come, I'll give you a letter excusing you from coming back from my funeral. And, or others, if let's say Thanksgiving or Christmas, when children have to decide who they're going to go to, the in-laws or you, and I say, just play your card and say, "This is the situation. I expect you here for Christmas." And I said, "You may lose your credibility after a couple of years, but that's okay." And it's important. There was one patient, I mentioned several examples in the book. He was dying of prostate cancer with bone pain, and he, I asked him that question, what do you want to do? And he said, "Well, I have 7 kids, and every time we get together, there's a million between the kids and the grandkids and so forth. I really haven't been able to sit down and talk to them." And I said, his oldest son was with him in the examining room. I said, "Fine, your son's going to make up a calendar and assign all 7 kids and grandkids that are old enough to come, and that'll be the day with you." And it worked. For a month or two, he was busy, got his rest, but he did it. And so it's important, the doctor really has to touch the patient and see where they're coming from, what they need. And unfortunately, in the current situation where doctors have 15 minutes and move on, at least in oncology, we're able to have the time, plan the time, because people need it. One of my favorite patients was, I have many favorite patients, some people. But was a 63-year-old woman who had breast cancer. And this was back when mastectomy was the standard of treatment. And she had a mastectomy, and margins were clear, and the nodes were negative, so she didn't receive radiation treatments. But she was seen by a medical oncologist in Boston. At that time, he put her on tamoxifen. Tamoxifen is an anti-estrogen hormone which suppresses recurrent breast cancer. And there was evidence that decreased recurrence in the first 5 years by 25%. And so she was put on it, came back to Maine. Her primary care physician religiously renewed her prescriptions every 6 months. And then finally, her doctor retired. So she saw a new internist, and he went over her medications. And the medications, he looked at them and said, gee, you've been on tamoxifen for 15 years, and you're only supposed to be on it for 5 years. And they've done studies where 10 years was no better than 5 years, and you don't need side effects. So he said, I'll take you off of it. And she did well and was fine. And then 3 years later, she developed an ulcer right in the middle of her mastectomy scar. And the surgeons biopsied it, and it was recurrent breast cancer. This is 18 years after her mastectomy. And they resected the ulcer and with margins, and then we radiated the chest wall to make sure there was no more cells left. And by the time we finished the radiation treatments, this 81-year-old, 4'11" woman looked me straight in the eye, wagged a finger in my face, and said, God help the next doctor that takes me off tamoxifen. She was a pistol. I followed her for 3 years. She did very well, and I'm sure she died with tamoxifen several years later. But that's another. You can stop me if you have any comments or questions as I go. Another patient, which is end of life, was a patient whose family I knew, and she had breast cancer and had metastasized. And so for the last 8 years, we were treating metastatic disease. She did respond to hormone treatment and chemo and had several episodes of radiation therapy, and then came into the hospital for pain relief. She had a painful bone lesion that we were going to give radiation treatments to. At this time, her liver was also involved. And she came in, we planned out the treatments, and then was upstairs ready to come down for her first actual treatment. And I get this frantic phone call from her daughter, who was upstairs in her hospital room, saying, Dr. Gilbert, you have to come up here and speak to my mother. She's refusing to have treatments and doesn't want doesn't want to have any more. And I said, okay, I'll be up shortly. And I went upstairs, and before I went in, I looked at the hospital chart, and I could see that her liver function tests were going way up. And the liver is probably the best way to go, because it's usually painless, and you just go to sleep and when the so much of the liver is involved. And so I went in there and I said, "What's going on?" And she said, "You know, we've had a good 8 years, a good quality life, and but I'm tired and I'm sick of treatments and I don't want to have any more." And I said, "It's okay, I'm not making a mistake." And I heard a gasp from the daughter who was actually standing at the window, and if looks can kill, I would have been dead. And she more or less said, "Who the hell are you to throw in the towel on my mother?" And after a long 30 seconds, she walked over and sat down next to her mom and sat there holding her hand. And I left. And she died in the hospital 48 hours later. And I never, well, I saw the daughter a couple of days later, and she told me that, well, I should say that Kubler-Ross wrote about death and dying, and there's 5 stages of getting bad news, and one is denial, and anger, depression, negotiations. Get me through this, and I'll build you a church. And the 5th one is acceptance, where you say, "This is the hand we've dealt with," and so forth. And in retrospect, both the mother and the daughter went into acceptance in that 30-second pause. And she said that for the last 48 hours, she sat there in that chair, and they talked, and they cried, and they laughed, and they reminisced, and the mother gave her instructions. She said it was the most precious 48 hours I ever spent. And, most people use dying as desperately trying to stop the time from coming in. It's a very precious time if you accept that we're all going to die. Well, she also sent me a letter, which I'll read part of. "Dear Dr. Gilbert, my mom was a great lady in many ways, and I know that her death will leave me with a sense of loss that can never be completely healed. That sense of loss, however, will always be held on a balance of all the things that she gave me and that I learned from her. The greatest lesson that she taught me was to live life to its fullest because it is precious, to fight for as long as one can, to live that life, and to let go when it's time. Thank you for helping her to fight, but later for giving her permission to go. I'm personally invested in healing my mother, but you seem to understand that her very soul was central to the healing of her body. Once it was past time for her body to repair itself, you gave great respect to her soul. I will be forever grateful for your simple words. You are not making a mistake." And that experience was a game changer for me, because you realize that you really had to help, and doctors can do a huge service to their patients in getting them ready for that, and getting the family ready for it. And it's supportive care and hospice became a lot more important in my armamentarium. And many patients would, would come with metastasis, early metastasis, and would say, "I went out, I don't want to go through this and living with incurable cancer." But then you tell them, "Listen, it's not time, but I'll tell you when it's time." And hold up. And if you can have that understanding with the individual and the patient, you can do a lot more service. Let me give you one more and then we'll open it up for questions. One of my most memorable patients was a 17-year-old girl, was a great athlete, and she was a star here in high school, and she had a Ewing sarcoma of the left femur. That's an unusual tumor, but it occurs in younger young boys and girls, actually. Peak age is 10 to 20 years of age, and so she was 17 right in there. And it does respond to radiation and chemotherapy, but the patient was seen by a surgeon, and they recommended an amputation of her left leg. She came to see me, and I was aware that there were papers and reports that combination of chemotherapy and radiation therapy, which was just really getting started and combining both, had a 90% chance of controlling local disease. And but I didn't really have the guts to make that recommendation because I didn't want to risk put a bet on it. So I called my old boss, who was the chief at Mass General, and who was the world's expert on radiation therapy of sarcoma, and listened and said, sure, I would give chemo and then combine radiation and chemo to the primary tumor and watch it carefully, and if there's any sign of activity or recurrence, you have to amputate the leg. And so we gave her chemo, radiation chemo, and she tolerated it very well. And the tumor disappeared and was under control. In fact, when she was getting her radiation and chemo, she set the Maine State indoor shot put record. And she was really, my daughter was in track at the same time and was at that meeting. And she said, geez, she has the greatest curly hair. And I didn't tell her it was a wig, but it was a wig. And, but anyways, she did well, and we followed her and made sure that there was no evidence of any recurrence. And then about 6 months later, I was seeing patients at Maine Med, and her mother walks into the department and was sitting down, so I came out of the room, and she said, I have a favor to ask of you. And I said, what's going on? And she said that Angie was having a CAT scan of her abdomen, and her medical oncologist thinks that the tumor has recurred in the abdomen. And she only wants you to tell her the results of her CAT scan. And that was the hardest request I had in my career. About a half an hour later, I went over to X-ray, and sure enough, she had liver metastasis. So, some tears and hugs, I showed her the scan and said, this is what's going on, but this is what we're going to do. Whenever you get bad news, you really want to counterattack the start as soon as possible. And I assured her, like should to all patients, we're not going to abandon you. We're going to stay with you all the way. And she passed away about 4 or 5 months later. But to my big relief, the tumor in the leg never recurred. So these were small microscopic metastases that had already gone. So if they amputated the leg, it would have been like closing the barn door after the horse is out. And the patient passed away, and then I wrote the piece about her, and then I sent it to her mother, which was 25 years after the incident. And so I sent her this chapter, And she wrote back last year, said, "Dear Stu, I read your email and I am still smiling. You have written this piece with love and deep understanding. Thank you so very much. You have explained to me something that had bothered me all these years. I had always wondered what would have happened if we had amputated her leg. Now I am very convinced that we did the correct action, and deeply thank you for this peace of mind I now have." And in the book I say, "I was disturbed by Angie's mother who was bothered by the thought that her amputating her leg have led to her demise. I believe the doctor's responsibility does not end with the patient's passing. Bringing closure and comfort to the family is important too. Although I have seen the mother several times after Angie's passing, her concern was never mentioned to me. For me, the reassurance that not amputating the leg did not affect the outcome came 25 years later. It came 25 years too late." In a previous talk to our cancer support group, I said that I was relieved that the tumor didn't come back in the leg and that not amputating did not cause, because I would have been devastated. I would have had to live with that the rest of my life. And a patient who had cancer said, "You know, I never realized how much skin the doctor has in the game." It's no joke that the difference between a pre-operative checklist and a pre-flight checklist is that the pilot's on the plane. But the doctor has many sleepless nights when you make a decision and then you say, "Gee, I hope it's the right decision." Thank you for listening. And any questions? I can give you more.
Doctor, I've been lucky enough to have doctors like you in my life. But what do they teach in medical school? Glove on, glove off?
Well, now of course, I went to school 45, 50 years ago, and we did. You learn the science of medicine, and you get judged by your knowledge of science and medicine. Now they are making an effort. I know that most medical schools have simulation booths where they can videotape, and they'll have actors come in. And how you handle different situations, and then so somebody's in there, one student's in there, and the other students are with the professor, and then you can analyze. You really, I wish there was, well, this is one way of telling people how, especially physicians, how they can really impact somebody, even if they have nothing to offer scientifically. And I gave this talk to the medical oncologist down in Maine Med last week. But they are trying to do something, but there's no formal education. And you know as well as I do, there's some people that can do it and others don't. And nowadays, people have assigned times, and it's very hard. When I shared the story of a bilateral mastectomy patient with the surgeon, and he read it, and he said, "Gee, I wish I had an hour and a half to spend with my patients because I can accomplish so much more." So, at least with oncology, you know the patient has, you have their full attention. It's not a minor problem. And so we had planned an hour and 15 minutes for each patient. So there's no easy answer.
You mentioned a couple of times where you sat with a patient and they expressed a need to stop treatment, and your response as the doctor was to nod and understand that need. Do you think that that is unusual? Do you think it's obviously something that's been talked about a lot recently. Do you think that that's loosening up a little bit and that attitudes are changing about the importance of that time and sometimes stopping treatment?
I think things are changing, and you know, it's an interesting study which was recently done, which is almost counterintuitive. End-of-life cost is a huge expenditure in the United States, and it is inversely related. The higher socioeconomic and economic status, less to spend on end of life than the lower end. And I think that, you know, if somebody, and it starts with the education of the patients and empowering them to make the right decisions. And, you know, if you understand your situation and you understand, okay, I've had this, I've had that, you know, that's not a bad choice. And I think if you took a survey here and really understood the situation, people would say, I'll be fine at home. And so it is education, and it's also relationship. I mean, if you're a new doctor, just seeing a patient, it's very hard to say, yeah, it's okay to end, because you don't have that relationship, you don't know where you're coming from. And the dynamics is very interesting, because you spend a lot of time with the patient and the support family, the local children, and everybody be on the same page. And then some other child from Philadelphia flies in and says, wait a minute. And you can't, you know, you have to do this, you have to do that. You know, death is a dirty word in the United States and must be avoided at all costs. And unfortunately, you know, it's an educational process, and unfortunately, it's a political process too. You know, Sarah Palin saying death panels. It's
Are you doing any teaching?
well, I spoke to the medical oncologist 2 weeks ago. I've been talking a lot about this, and but it's you know, I'm willing to. In fact, I sent the dean of the medical school, who I know, gave him my book, and so he's going to read it. I don't know what he'll do with it, but yes, sir.
It seems like your particular practice brings you very close to death a lot of the time. I'm sort of interested in whether radiation has, how does it affect quality of life that is being applied? Has it gotten more sensitive in recent years for, you know, are they able to do a better job? And to what extent does it impinge on the quality of life?
Yeah. First of all, you reminded me that practice, you know, I have one chapter on God and cancer, and you know, and the experiences of God coming in with different conversations. But you know, radiation therapy now, machines are it's all in the computerization, and they can aim the beam and protect organs. Radiation therapy is localized treatment, so it doesn't replace chemotherapy, but they work together. And obviously, we're there to improve quality of life, getting pain and avoiding a life-threatening problem. But it is, you know, it's tough medicine, and the actual treatment, patients are tired, and hopefully, the reason we give the treatments is that the tumor cannot hopefully tolerate the radiation treatment. The normal cells will get irritated, but then will recover. It's the same thing with chemotherapy. So, and each patient is different, and so I think that you know, young doctors used to ask me, he said, "What are you going to do after what? You know, what's next?" And I said, "The patient will always tell you what to do." And you see if how the patient tolerated it and how the tumor tolerated it. And then you'll say, well, they both tolerated it. If it's working, we'll continue. And there's one patient in there that was sent to me with incurable disease, and a very prominent person in the community. And she accepted it. She said, fine, I don't want to spend the rest of my life in a vain attempt that it's not going to work, just to try to live forever. And so she refused, aggressive treatment, but we gave her some palliative treatment, which is just to make her feel better and take the pressure off the tumor. Gave her a little radiation, a little chemotherapy, not much as far as cancer treatment, and she had a remarkable response. And we said, wow. And it was involving her bile duct. And I said, I can't see the tumor on a CT scan, and the marker of the tumor had gone away. And I said, I think you should have a laparotomy and a surgeon go in there and see exactly what we're dealing with, because I wouldn't expect this. And she refused. She said, I don't want surgery. I don't want to go through procedures I don't want to spend the rest of my life doing that. But we talked, and I wouldn't, finally I convinced her to have a laparotomy, and she had a laparotomy, and the tumor was gone. And she was given a death sentence. And but it wasn't 3-4 years later, she had some recurrence in the liver, the right lobe of the liver, and because the markers started creeping up, and but the right lobe of the liver could be removed, and so she had surgery 5 years later on the left lobe of the liver, and I went to her 80th birthday party 15 years later. So it really, as I said, you can't. And she was turned down by two of the smartest people I know, and as incurable. And but everybody deserves a chance at let's see how this works. And if it works, then you listen to the patient and follow the lead. Thank you very much for coming. Thanks.